Very good evening to one and all. I, as Vaidyanathan, General Manager Marketing from Zuventus, take this opportunity and extend a warm welcome to each one of you, the August gathering of medical fraternity, for the inaugural webinar titled Brain Mantra. And it is indeed a pleasure for all of us to have all of you with us here for this enriching scientific deliberation. Before I begin, to give a brief introduction about Zuventus, Zuventus is one of the fastest growing companies in the healthcare arena and has a reach amongst wide therapeutic range, which includes anti-infectives, vitamins, minerals, cardiac, anti-diabetic drugs, to name a few. And they have made an indelible mark in terms of serving the patients and making their lives better each day. And today we have with us our medical team headed by Dr. Bhupesh Diwan, who's our medical director from Zuventus Healthcare. Welcome, sir. A warm welcome to you. And also we have Dr. Sanjay Nevale, our Assistant General Manager Medical Services, who will moderate the session along with Dr. Shefali and Somaya from the Zuventus team. And before we actually begin the proceedings for the day, I would uh, send a communication here that this webinar on Brain Mantra is a unique scientific series. In fact, this is the inaugural episode which we are starting today and which is going to culminate into a 6 series episodes starting from today. And to do the honors, I would request Dr. Sanjay to introduce the eminent speaker for the day and start the proceedings. Over to you, Dr. Sanjay.
Thank you very much. Good evening, respected doctors, and very welcome to the first episode. So this is a web series. So this is the first episode of Brain Mantra, a webinar series on developmental disorder by Dr. MonaGajre. So I take a pleasure to introduce Dr. MonaGajre. She is a practicing pediatrician, neurologist, epileptologist, developmental disorder specialist at Dr. L.H. Hiranandani Hospital, Powai, and Surya Hospital in Chembur in Mumbai. She is also full-time professor at Lokmanya Tilak Municipal Medical College, famously known as Sion Hospital. So she is a professor and she is a head unit there. So this is very big achievement. Over the years, she has a 26 years of teaching experience, guiding the trainees in pediatric neurology, epilepsy, learning disability, and developmental pediatrics. So she is also a member of IAP, Society of Developmental and Behavioral Pediatric, to name a few. She has been a principal investigator for international as well as national trials, and she has a 56 publication to her credit, out of which 22 are international publications, and she has authored chapters in the 6 books. So welcome, Dr. MonaGajre. So we will be happy to hear you. Over to you, ma'am.
Thank you so much for this warm welcome. I'm very happy to be part of this unique webinar, and it's been a great it's a great opportunity to be here and share whatever my inputs are on this. So it is a very unique concept by Brain Mantra and Zuventus, to start this webinar on tools in pediatric neurodevelopmental disorders. Especially post-COVID, we've seen a great rise in virtual autism and other neurodevelopmental disorders. And it is now the need of the hour, because I remember whilst I was training as a medical resident, there was not much awareness of pediatric neurodevelopmental disorders at all. In fact, I remember after my PG training, and I'm talking about the late 1990s, early 2000s, was that I was asked during my appointment as a resident doctor in a private corporate hospital, which I had gone to, was about what were the symptoms of autism. And in my 3 years of medical training in a public medical college in Mumbai, I had not seen a single patient of autism. And the attending person who interviewed me was a very eminent pediatrician. He was pretty shocked to know that. And retrospectively, when I think, a lot of children of autism were put under the garb of intellectual disability or mental retardation, as we used to call earlier. So they were kind of missed out and, missed from the society, hidden from the society. Of course, now with the awareness of neurodevelopmental disorders, things are looking much better than what they were. So with this background, I just want to run through that when this subspecialty of neurodevelopmental pediatrics has begun. So as we know that neurodevelopmental pediatrics is an emerging pediatric subspecialty. It is also known as DBP. So the person who passes out from here is known as a DBP, or developmental behavioral pediatrician. Okay, and it deals with the diagnosis, treatment, and management of children with developmental disorders. Usually, children suffering from developmental problems from the 5 domains that we know of, that is motor, language, social, communication, cognition, activities of daily living. So any issues, so that is why we see a lot of children with either generalized developmental delay, specific delays in say language domain or cognitive domain, etc. A developmental pediatrician is also referred cases with behavioral problems. Now, what do we understand from the term of behavioral problems? As we know that behavioral problems or issues could be either internalizing type of behaviors. That means that the child has say depression, or the child has selective mutism or something like that, or externalizing, which is very troublesome to the person in the environment, or the caregiver, or say the school teacher, etc. So these could be ADHD, oppositionality, or defiance from the child. So all these kind of behavioral problems which are not handled in office practice in a general pediatrics office can be referred to a developmental pediatrician. The developmental pediatrician typically looks at children from 0 to 18 years of age. And now with the rise in adolescent health, it almost covers the entire spectrum from early childhood, infancy, and up to adolescent age group. So recently there has been, say, the last decade or so, there have been formal training in the field of neurodevelopment pediatrics. It is usually a 1 to 2 year fellowship programs which are happening in multiple medical colleges in the country. And also the IIP also runs their fellowship program. In fact, I'm happy to say that Sion Hospital was one of the first hospitals to begin with a developmental pediatrics fellowship program way back about 10 years back. It was the first in the country to begin this, and we began it in collaboration with one of our US partners. Interestingly, developmental pediatrics is also a new subspecialty even in the US. It began as an offshoot of pediatric neurology, and it is a cross or an intersection between neurology, a little bit of psychology, a little bit of pediatric psychiatry too. So what are the common neurodevelopmental disorders that one encounters in office practice? One is, of course, autism, then ADHD, which is also known as attention deficit hyperactive disorders, specific learning problems, intellectual disability, cerebral palsy, some sensory processing disorders, and behavioral disorders. So what are the behavioral problems, and whom should, the usual question is, whom should behavioral problems be shown to? I personally feel that pediatricians see more of these children, and they are the right person to look at children who are suspected to have a behavioral problem. We know that behavior is a product of the child, okay, and also of the environment. So because pediatricians, with their training and the bond that they have with the child and the parents, especially when they're seeing them right from there, they know the family background much better than any other professional. And so a lot of these problems, now in terms of behavioral problems, it could be temper tantrums, it could be thumb sucking, it could be bedwetting, etc., or encopresses. They can be solved with simple solutions given during the office practice. So we will look through them, or we will go through them in the following presentations. So coming to just an overview of what are the behavioral problems, ADHD, as I said, again, you can see ADHD right from preschool age onwards to even adolescent or even adulthood. Then anxiety, depression. You will be surprised to know that a recent paper from the United States said that maximum of school children, and this is of course a United States paper, maximum they found that when they did a cross check section across the country, they found that anxiety, depression, as was our typical thinking that it usually occurs in more than 10-year-old, they found that the highest proportion of anxiety was seen in early childhood. So from children from 5 to 8 years of age have high levels of anxiety vis-a-vis older children, which they used to see earlier. So that is the trend which is following in the United States, and I hope that we don't see this trend in India coming in the next couple of years. Now, again, in behavior, you could have disruptive behaviors, and these are eye-catching because it troubles everybody in the environment. It could be the teacher, the parent, etc. And as I said, it could be oppositionality or conduct problems where the child has this, burns up things and doesn't listen to anyone, kicks pets, etc. Eating, panic, internet addiction, disorders of personality, these are again seen more in adolescent age group. Now coming again, changing gears and just to know that who is a DBP, when do you refer to a DBP? So the DBP is a qualified personnel who has undergone a training post MD, and they are people who deal from children from the newborn age to adolescent, and they deal with attention problem, behavioral problem, other tics or habit problem, regulatory disorders like sleeping, feeding issues, toilet training issues, bedwetting, encopresses, which is soiling their pants, developmental disabilities, any delay in speech or language or motor skills. So how does the DBP differ from a pediatric neurologist and epileptologist? Both, of course, are post basic specialty trained people, post specialty. They have trained for a few years in that field. And in addition to the neurologist, the training is more focused to seeing structural causes of the brain function. So it could be infections, congenital malformation, muscle problems, autoimmune issues, migraines, etc. At the medical college that I train, we have both the fellowships in pediatric neurology as well as developmental disorders. So now coming to autism spectrum disorders, we have heard a lot about autism, especially virtual autism post-COVID, and we know that autism spectrum disorder involves a defect or a deficit in social interaction, communication, and repetitive behavior. So what is this difficulty in social interaction? So social interaction, you will notice that a child may not make an eye contact and may not point at things. So, before when we are born when the baby is born, the child is able to communicate as early as say 1.5 to 2 months or 3 months of age. Typically at 2.5 to 3 months, when the social smile is achieved and the child looks at the mother, gives a sustained eye contact to the mother and smiles at the mother. So that is the first social interaction which happens. Later on, as the child grows, before the language comes in, the child is pointing out to things that they want. So that is a form of non-verbal communication which happens. And it is, of course, a milestone in the social interaction that is achieved. Now, as before there is expressive language, the child understands the language first. So when the parent calls out to the child by its name, he or she looks at the parent and responds to their name with a gaze, as well as looking in that direction. So and later on, when the child becomes verbal, you will notice that in forms of play, this child may not play with other children or simply is not interested with other children. So if the other child is playing, this child will be sitting in one corner and just doing his thing in a repetitive manner. Or even if when they go to a play area or a garden, the child is not much interactive or not very happy to see other children, which will typically comes at 1.5 to 2 years of age, when the child is very excited to see other children and wants to play with them. So in social interaction, there is a issue in children with autism. The next domain that is affected is communication problem. So these children will have delayed speech or a deviant type of the speech, where the speech is in form of echolalia, which we will see later on what echolalia means, or a scripted kind of a speech. Also in speech, in receptive, this is the expressive part of the language. In receptive part of the language, we know that language has two components, the receptive part and the expressive part. Receptive part means what is the understanding of the child. So the understanding of the child comes first before the child expresses or actually talks. Okay. So this child has a difficulty in understanding what others are saying. This child is more object focused rather than human focused. So they seek out, instead of seeking out humans, which is what neurotypical children do, they are more object fixated, right? And in fact, they seek out parents or the parents' help only when they have need. So it is more of a need-based communication from their end. Further on, as this child becomes a little older and language does come in, they have a difficulty of expressing themselves either verbally, that is by speech, or non-verbally. Non-verbally means through gestures, through facial expression, through smiles, etc. So they may have a difficulty with that. And the third component of a child with autism is this repeative behaviors. So you would see typically in a child with autism, because of their sensory seeking behaviors, they may have these stereotypies like flapping or rocking, etc. And they are very rigid with their routines. So anything, so, as a child wakes up in the morning, the child has to brush his teeth, then have a breakfast, then take a bath. If there is any ulta pulta in this routine, the child becomes extremely anxious, disturbed, and may throw a temper tantrum. So what are the suspicious signs for autism? So these are some of the suspicious signs, and this is pediatrics, and now later on the IAP, the special chapter has also adopted these guidelines. So no babbling, so no expressive language by 1 year of age, no pointing, okay, so no non-verbal type of communication, no sharing of enjoyment with the parents by 1 year of age, no word output by 1.5 years of age, no two-word meaningful phrases. Okay, that means the child may say I dood. That when the child wants milk, he will say, instead of I mala dood de, because that comes at 3 years of age. By 2 years of age, if the child is not able to speak I dood, that means there is definitely a suspicion of language delay, which could be autism. Any loss, any regression in speech, babbling, or social skills at any age is very significant. I would, in fact, ask everyone to please take a snapshot of this slide and please put it up in your clinics for educating your parents and the children at large, because these signs are really important. More or less, we are very well trained in motor symptoms and motor signs, but language and communication, that we may not be we are not much well trained during our training in pediatrics. And this is a very important slide which could be displayed for educational purposes in the office, in your office. So symptoms of autism usually appear before 3 years of age. In fact, the earliest child that I have seen with autism is been a 15-month-old child. And the earlier, it has been my experience that earlier that we pick up, the condition is usually more severe. So when I followed up, now this child of 15 months is about 5 years old, and he does have severe autism despite the therapy that has been given since 15 months of his age. Okay, so the symptoms appear before 3 years of age, And some of the red flags for autism is, as I said, there is no response to name. So when the parent calls out, Ankush, so the child will not look at the parent, behave as if it does not. So the parent will say हम बोलते रहते हैं, उसको बुलाते हैं, पर उसको वो ध्यान नहीं देता है, कभी कभार एक आधा बार देता है. So how many times should the response to name be? Now technically it is about 6 times. So in your office, if you have a child coming in and you call him by the name, you should give a trial of calling out at least 6 times before you say that the child does not respond to name. So 6 times, because sometimes by the younger children, that they get, when they come to a new clinic, they come to a clinic or a new place, they are very enamored by the surroundings. So they may be engaged in something else, looking at the wall or looking at some toys, etc., and they may not respond. So 6 times you have to call out without touching the child or without the mother touching the child. And if the child does not respond, look at the child. If there is no response further on, then you ask the mother, you just gently tap the baby on the cheek or the shoulder to get his attention. And if the child is facing away from you, then get the child, in your line of vision with the eye contact, and again see whether there is a response to name. If there is no response to name after doing these maneuvers, then definitely that is a red flag for autism. Again, going on to the second red flag, no meaningful words by 18 months of age. So a lot of children, or the parents will say, ये बात करता है, ये मम्मी बोलता है, ये पापा बोलता है, ये आत्या बोलता है. But then you have to ask, in development pediatrics, we do not for motor skills, we have a typical range, when the child started walking and running, etc. But in development pediatrics, not only we ask when the child has achieved a milestone, but the quality of the response or the quality of the milestone is very important to know where the child is functioning, because that helps us later on with the interventions. So meaningful words, going back to that example, so the parent will say, ye mummy bolta hai, papa bolta hai, kaka bolta hai. But then at that point of time, it is important to ask them, does he say to mummy, or is he just saying mummy to everyone? Okay, so meaningful means, a word means that. Does not play with toys appropriately. Now, this is a very important thing, right? Because as for us, our occupation is, seeing patients, or say for the other adults, it's going to office, etc. For children, their occupation is play. So how the child plays with the toys or with the peers, how the child interacts with the peers, gives us a lot of information on what is the functionality of the child, how is the communication skill, how are the social skills, etc. We also have to look out for echolalia. Now, echolalia means repetition. There are 2 parts of echolalia. Echolalia could be immediate, echolalia could be delayed. In the following slides, we will see what are the types of echolalia. There is always a fixed pattern of interest in activities. So this could be like, if the child is playing with the car, instead of playing with the whole of the car, and which is what a neurotypical child would do. These children are focused only on the part. So they will just keep on twirling with the wheel, or they will, if the car has a door, they keep on opening the door. So do these kind of activities instead of playing with the car. Or they'll keep on lining up the cars, and then they put their head down and they keep on watching at those cars. They could be having a repetitive behavior, or in terms of stereotypies, flappings, etc. The child could be hyper because of his sensory symptoms and be moving all around the place. It's very difficult to handle him, and the parents are usually at their wits' end. They will say, "ये बहुत मस्ती करता है, सब जगह पे चढ़ता है, उतरता है, उछल कूद करता है." The other sign for autism, and what was traditionally taught to us, is toe walking. So toe walking, that means they tiptoe around the house. That is not because of, so toe walking could be because of a motor symptom, a neurological problem. It could be a sensory because of the neuropathy. But in these children, the toe walking is because of the sensory part. So they have a tactile, which we will discuss in the further slides. that they have aversion to touch. So between you and me, if there is, a slight tap on a face, we just feel it like that. But for that child, this tap feels like a slap on his face. Okay, so that is why they avoid touching their sole or the heel on the ground, and that is toe walking. So a brief on how does actually social communication develop in humans or in all of us. So first of all, when it begins right in the newborn period, and if you notice or if you remember our training, we've always been taught that when the baby is born, uh, and the baby interacts much better with to the mother's voice. So when the mother talks to the baby or sings a lullaby to the baby, the baby will intently, look at the mother. And in fact, the gaze, or because the nature is so well advanced than the AI or even humans, that when the mom is feeding the baby's vision at during the newborn period and up to 1 month of age is up to that range. So suppose the baby mother is feeding, then up to that range the baby is able to look at the mother and register the mother's image. And it has been shown in multiple studies that when newborn babies were shown a male face versus a female face, they will look more intently to the female face versus the male face. They respond much more intently to the female voice versus the male voice. As they grow older, at 2 months, 3 months, there is an appearance of a social smile and there is interactive gaze present with the caregiver. As they grow old, a little at around 2 months of age, at 90 degrees to 90 degrees, they are able to turn their head to a sound. So they are able to localize the sound. So first is they stop doing whatever activity they are doing, they pause and they listen intently, then they turn their head towards the sound. A few months later, between 3 to 6 months, they recognize people around them, immediate people, mother, father, etc., or any other caregiver. Then they have this babbling. Okay, so babbling is it's a back and forth babbling. So if the baby makes a sound of ah, and if the mother responds, then again they will continue saying ah. It's almost like a talk, and this imitation and babbling is seen even in our ancestors, that is monkeys, etc. And that is, they've studied a lot of these monkeys, etc., and they found out actually how the social communication develops in them. And then they put this theory forward in humans, right? So this back forth babbling is also known as vocal tennis. It's almost like hitting a tennis ball across the racket, and that kind of babbling happens. At this point of time, how we learn actually is very interesting. Our learning is based on imitation. You know the story of the monkey and the cap seller, etc., right? And so that's how really our learning happens. If you break it down, really, this is imitation is where imitating is how our learning happens. Okay, so because we have something like mirror neurons in our brain, there's a lot of research done in mirror neurons. So mirror neurons are neurons pathways in the brain. So if they see, in terms of if the other person is doing another activity, in terms of an activity, in terms of a language, in terms of even spatial expressions, the person opposite, immediately it is picked up by the mirror neurons of the brain, and the activity is imitated in a similar manner. So you will see that, if during meetings, if a person is sitting in a very fenced position, in the sense crossed armed, etc., the other person will also imitate these closed body postures. So that is because of the mirror neurons which are present in the brain, and that is how imitation, and through imitation learning happens. Then this very important concept of joint attention comes in. Joint attention is also known as the triad gaze. So what that comes in typically between 12 to 15 months of age. So what happens is, we know that before the child talks, the child is able to communicate through the gaze. Okay, So if a child of a year old who doesn't have language yet, is not able to vocalize, doesn't have expressive language yet, no words are there, if they want something, how the child will point out? If they want a balloon, they will, use the finger, like a pointing gesture for it. Now, supposing if they want something which is, say, the kitchen accept attention, joint attention means that the child will go and look at that thing with the gaze, then look at the parent again to see whether the parent is following their gaze and look back at that object. Through the gaze, the child communicates with the parents even before word appears. So in neurotypical children, with only language delay, the thing that we have to ask is, बच्चा आपके साथ कैसे बात करता है? अगर बात नहीं करता है तो आपके साथ वो कैसे आपको कम्युनिकेट कर पाता है? So they will नजर से कम्युनिकेट करता है क्या? So just yesterday I saw in the OPD the referral was for a 2.5-year-old for suspected autism. This child had no language at all. Okay, only sounds, and that too occasionally. But when he came into the room, he gave me an eye contact. He's responding to his name. He looks at me, responding to his name. He's smiling. Then he looked at some picture or some toy which was there on the shelf. So he looked at the toy, he looked at me, and again he looked at that toy. So this is the triad gaze or joint attention, which is a very important thing. So of course, the child is not able to communicate verbally, but the child was able to communicate through gaze. So this is not autism. This is a language issue. Okay, so a language delay, a expressive language delay in this child, right? So again, now going on to social communication, whether there is a single word with meaning present comes in later, say at 1 year of age, then 2-word phrases, as I talked about earlier, then the child talks in sentences. Okay, instead of saying, "Mummy, दूध," the child will in sentences say, "Mummy, दूध do." Okay, and then longer complex sentences, verbalization comes in, and then when the child comes back from school, say a playgroup child, the child can narrate to the mother exactly what has happened in the play during the school hours, etc. What happened during the playgroup teaching sessions or during the break, etc. So common conditions that one should look for in addition to the when we suspect a child to have autism is anxiety. Anxiety is seen in a huge percentage of these children, and it typically takes form of temper tantrums, rigidity, hyperactivity. Okay, so it can manifest in this type of behavior. The underlying symptom is anxiety. Obsession, compulsive disorder, irritability. They are very quite irritable. They don't like changes in routine. Self-injurious behavior is more common in severe autism. Again, during my practice, I have not seen SIBs or self-injurious behavior a lot compared to what our developed countries counterpart sees. A lot of sensory disturbances are seen. Sometimes these children can have intellectual disability associated with it, seizures, constipation. The idea of putting up this chart is that we don't only say autism, but these comorbidities are to be looked for, and if present, we have to treat them. So coming on to sensory disturbances, this is present almost in most of the children, 80 to 90% of the children. And so we know that we have 5 senses, but in terms of therapy, in terms of the occupational therapy training, and which is done as per the Avers pyramid, there are 7 senses which are present. We know of all the 5, which is the touch, and then the vision, the hearing, the smell, and the taste sensation. These are our 5 basic sensations which you talk to us in medical school. But the 2 additional sensations which are proprioceptive and vestibular. Okay, so these sensations are very important. Proprioception is, we know that the proprioceptive receptors are present at the joint. So it gives you a sense of position and balance. And vestibular is also for balance. And so that is why you will see that these children have a little uneven shuffling kind of a motor problem they can have, or they have these seeking, vestibular seeking behaviors where they keep on rocking. The idea of the child rocking is either because of anxiety, it could be, or they have this sensory seeking. So they have a low threshold for vestibular sensation, and so they rock to kind of stimulate the vestibular system and to have a sense of awareness of what their how they are placed in the space, right? So they to sensory problems, it could be of all the seven senses. Either they have an abnormal reaction to sound. So we call this as auditory overactivity, where they cover this. Okay, and you must have seen in My Name is Khan, Shah Rukh Khan's movie, that he used to wear this audio phones to decrease load which is there in the environment. And they can have access to in objects, like if there is a wood, or if there's a mobile phone or something, they'll keep on smelling it. If they have tactile under sensitivity, they keep on touching things, and that this is thought to be thought as a hyperactive behavior, but it is not. It is just part the child is trying to touch things because his tactile there is hyposensitivity. And all these sensory symptoms get better with occupational therapy. Again, with fascination with lights or moving objects. In one of the other Bollywood movies, Barfi, if you remember, that Priyanka Chopra used to carry a very small piece of mirror with her. So she would not have a direct gaze, but through the mirror, she would flash the mirror, and through that mirror, in the image of the person in the mirror, she used to look at the mirror and have the gaze there. In fact, she used to communicate with Ranbir Kapoor by flashing the mirror. Okay, and even in My Name is Khan, you would have seen that there is no direct eye contact because they get totally overwhelmed with even a minor visual stimulation, right? So the importance is to know that what we perceive as behavioral problem is because of the sensory disturbances in this child, either over sense stimulation or under stimulation, and the child tries to adapt, okay, to the environment doing these behaviors, right? And these behaviors can totally be controlled or can be modulated using occupational therapy. Coming to the differentials for autism, hearing loss is a very close differential. So it is almost an unsaid rule that once we suspect a child with autism, we have to do a hearing screening. Then children with selective mutism can sometimes mimic children with autism. Developmental global delay can sometimes mimic autism and intellectual disabilities. So we will now go through a case of how early to pick up early warning signs of autism. This case is of a 2-year-old child. So why I'm harping today on early pickup is it has been my experience that earlier that we pick up children, in fact, at say 1.5 years, 2 years, we've done therapies or evidence-based interventions in these children, the outcomes are extremely good. Especially mild children, where the child has been picked up very early by a vigilant parent or a caregiver, then I have seen that if you institute interventions earlier on in a very controlled manner, with the pediatrician being at the center of the therapies or the interventions, the outcomes are excellent. When I've seen these children, say interventions done at 1.5, 2 years of age, and when I've seen them later at 4 or 5, it is almost like the autism was never there. They catch up very well with the language. Their behaviors are always under control, and they're doing very well in the regular schools and regular society, right? So as I mentioned earlier, that often children who are diagnosed early, okay, which is they're all the symptoms are almost in your face, and they come with very severe language deficits, or say hand flapping, toe walking, etc. But it is important to remember that autism is a spectrum disorder. So you have these mild cases, moderate, and the severe. So as I again reiterate, the severe ones may come in much earlier, and the milder ones come in a little later. So because of my position as a certifying authority for learning disorders at there, I have seen children with autism being picked up as late in the school, okay, especially the adolescent age by 10, 12 years of age. And these are mild autism children. And since the teachers, school teachers know that there is something amiss in this child is not mingling with the others, with the peers, and is being bullied a little or a little different, they generally refer them under the garb that nahi isko kuch learning problem hai, doctor sahab aap dekh lijiye. And actually it is mild autism which is presenting as a learning disorder. This again, typically we see only in India. We do not see this much in the development countries. Highlighting the point that autism is mild, moderate, and severe. Sometimes mild cases can be picked up even in adolescent. So early, if you pick up and if you are able to, pick up on the early warning signs or the early symptoms that the caregiver says for autism, as I said, the evidence-based interventions are extremely good, and there is a very good recovery or very good improvement that we see with therapy. So we will, and it also helps. So if we suspect a child or we see some symptoms, and these symptoms are all these symptoms which I discussed in the previous slide, these are all clinical symptoms, okay? And if we suspect clinically that this child could be having autism, then in the following, in a second series of the lecture, I will demonstrate and I will take you through how we can screen this child for autism so that therapies can be instituted early. Your role as a pediatrician cannot be understated, because it's not just about the diagnosis. You are going to follow up this child through his infections. He's developing as any other typical children. So infections, immunizations, etc. And that point of time, counseling the families, giving them the support that therapies have to be continued and medications, if required, have to be taken is very important. So your role is primary and very central in when we suspect, screen, and evaluate these children with autism. So let's now go to this first case. So this is what happens routinely. We know as doctors that we are consulted even outside our perimeter of the clinic, usually in social setting. So I'm going to take you through this very typical something which we can all relate to. That say we are attending a family reunion and Anisha is your cousin, and she says that she has noticed something about her development of a child, Manav, and she starts crying and weeping, and she says that Manav is 2-year-old, going to be 2-year-old next month, so he's about 1 year 11 months, and she sees that he's a little different from the other children on the playground. So she's a very vigilant, alert mom, probably because she's your cousin, so obviously you have passed down certain traits to her. And so she says that though he's an affectionate child, he's happy, he's in his own world, and he's not very demanding. His behavior can be sometimes very unpredictable. He's very shy. He has terrible temper tantrums, and they're so severe that she has to give in, and any change in the routine, it throws Mano off course, and she's worried because she cannot predict that what has to be done and how to handle him without causing a scene. She is embarrassed sometimes and a little scared to take him out in unknown settings because she's not sure what his reaction would be. So she asks, so you ask her that she's going to another pediatrician colleague who has been seeing this child right from birth, giving vaccination. So what does that pediatrician colleague think? And Anisha, to your surprise, says that this child, she has discussed this with a pediatrician about the temper tantrums, and her pediatrician says that the child is still young, or he's not talking, no problem, boys talk late, and he'll grow out of this phase. And because this pediatrician's office has some fish tank there, this child is very fascinated by the fish tank. So Manav is on his best behavior when goes to his pediatrician's clinic. and he's just standing near the fish tank and he's very calm over there. So he's not displaying any of his behavior. So the pediatrician has a problem, accepting what this mom is saying. Manav's doctor or the pediatrician has told the mom that maybe it is a problem with terrible twos, and you should be paying a little more attention to this child, and you're just overthinking and anxious. Now, the background also is that this mom has parents have had fertility issues, and so they've done IVF, and this is during their newborn period, it was not a very happy parenting for the mom, because this child had had infantile colic, was a very fussy baby, though otherwise healthy. So now, what are the discussion points which can arise through this? Discussion questions which can arise through this. So the points which arise is, it's evident that Anisha, your cousin, is worried about Manav's shy manner. So what are the typical social skills that most children obtain by 1 year of age, by 1.5 or 2 years of age? That is the background that we should be knowing this before we talk to Anisha. We should also have a knowledge that how should we differentiate a child who's shy between versus a child with autism, say. Also, would you want to know that any other milestones in Anisha? Anisha has just talked about the social milestones now and communication problem and more of the behavioral problems with you. Do you would want to know what is about his other milestones? And would you again talk to Anisha about, or would you want to know about why she's saying that his temper tantrums, the child's temper tantrums, are difficult to control? What do you want to know a little bit detail about it? And finally, what is the strength of this child? Like, okay, mom talked about all the problems, but what is the positives of this child and the family? So these are the 5 questions which come to our mind, when we have such a case. So I think the chat box is alive and well. So if I could have a little interaction, and maybe the moderator can tell me if there are any answers to these questions before I proceed ahead. So Aditi, are there any questions in the chat box to these questions, answers to these questions?
No, ma'am. I can't see the answers.
Okay. Should we give a minute or should I proceed?
Ma'am, there are questions. They have already put their questions.
Okay, great. So let us proceed with these questions, and then we can take on your questions. So first of all is that we need to find out at 12 months of age, as I said, respond to name comes. So when the child is called to, there will be a response. The child, if cannot communicate at this point of time, cannot say words, will be able to point to an object or gesture to an object to get what he wants. At 18 months of age, remember we talked about joint attention coming in. Joint attention, the triad gaze, able to communicate with the caregiver using the gaze. Why I harp so much, or why so much of focus on joint attention, is because there is a program called as JASPER, that is Joint Attention Program, which is used in early intervention in children with autism. So this program is typically focusing on joint attention, how to develop joint attention in children with early autism. At 2 years of age, a child should imitate, should show excitement, interest in other children, wants to play with them, though will not play with them, but play next to them, and is generally interested in children. And if you notice that a shy child, so a shy child will be hyper vigilant versus a child with autism. So they are in fact more cued in with the environment. They look at if they come into an unknown place, like say a doctor's place, they will hide behind their mother. They may not have a direct eye contact with you, but they look to the mom, they'll cling to the mom, and over a period of time, they will hide behind the mom, And but when you ask the mother, they will say that नहीं आपके clinic में ही ये ऐसा करता है, बाहर तो एकदम शेर है. So that is like typical thing. But there are some cases of selective mutism, which again I had seen a child about 4 years of age where the parents were suspecting autism, doctor parents, but this child had selective mutism. So the child will not, even with the parents, was not very open, used to open up. But this girl had her room and she used to go to the room and she used to play with her dolls and she used to talk to them, she used to feed them. So she was doing all kind of pretend play, imitation, etc. behaviors, but not talking with the parents or with the other people. And eventually I see her now as a young 18-year-old, and she's like totally blossomed out on her own and extremely good. In fact, she's going to take up medicine soon. So in the language domain that we look at these children, we should at least by the age of 2 years, they should understand 50 words. So as we discussed earlier, that receptive language comes much more earlier than expressive language. So understanding comes first before talking comes. Then 2 words together can point to certain objects, can follow simple instruction. Okay. Then in behavior, if you ask where is, say, pani ka glass, then the child will look at those behaviors. Sometimes those terrible tutor defined because they are trying to establish their independence. Okay, so say they've learned to walk and now they want to they know that they want to show that they are independent. So sometimes defiance can be seen. However, the red flags in this is if there's typical repetitive behaviors like flapping, which we talked about, and rigidity to routines, etc., can be played. So in play, as I said, play is very important to know how the child plays. If you ask them, if you've written an object, the child will be able to find that out. If you do, they have very good sorting things. Okay, so you mix up various colors, shapes, and ask them to put them in the shapes, etc., and or ask them to pick out colors. They are able to do it, and they do pretend play, as I said, like so they put the doll to sleep, then feed the doll, etc. These kind of behaviors they will have. Now coming on to temper tantrums, we have to address temper tantrums and what are temper tantrums, when is it normal? So temper tantrums are a normal in during development, but if they are, say, lasting for more than half an hour, if they persist beyond 4 years of age, if the number is very high. So what is a high number? In a month's time, 50% of the time, that is 15 times in a month, if the child has temper tantrums at home, or 7 times outside home in a unknown area, like out of home environment. So we said if it is more than 4 years of age, if they persist in this manner, if they are longer, more than half an hour, the frequency is high. If the child is not able to self-regulate, means not able to, come out of the temper tantrum, keeps on crying or screaming despite it being half an hour, 45 minutes. If the child is hitting out to someone else or hitting himself, biting himself, hitting, kicking during that half an hour period, not basically the underlying factor is not able to self-regulate. He doesn't quiet in time. He keeps on sobbing even after the tantrum is over for 1 hour, 2 hours. Then this is definitely a cause for concern. And we must always address the temper tantrum issues, and we will see further on what are the techniques to address temper tantrums, because it is very disturbing to the parents. And of course, we must know about the other milestones of the child, and we must explore what are the strengths, because again, we know that the interventions in children with autism is not going to be like, you give him, say, some medicines for malaria and typhoid, etc., and it gets over in 7 days, 10 days course. No, these interventions are going to be for a year, 2 year, etc. So compliance is extremely important. So knowing that what the strengths of the child are, so strengths of the family helps us immensely in counseling. So we should always point out, if the parents, because they're so overwhelmed with, these temper tantrums and the child behaving a little different from the others, we should point out the positive, that your child is a happy child and his motor milestones is attained well. These children, almost all children with autism that I see are very good rote learners. So they will know the alphabet by heart. They have good, they are able to count till 10 in English, etc. And the mother thinks that the child uh, is a very smart kid. So we are almost, we have conducted the session for an hour. We have a part 2 for this case, which we will be taking next time. So I would request Dr. Sanjay that if he could take any questions which are there in the chat box.
Yes, ma'am. Thank you very much, ma'am, for this very knowledgeable and informative session. Actually, this information is, it will be awareness for the pediatricians, actually. I have seen many pediatricians, they are not aware of this disease, actually. So this will be a very awareness session for them. And my colleagues, Dr. Sumaya and Dr. Sefali Roy, they will moderate the questions. There are many questions I can see in the chat box. So, Sumaya?
Yes, sir.
Okay. Sumaya and Sefali will moderate the session.
Sure.
Okay, so the first question is by Yalappa Gudagudi from Gokak, Karnataka. What is the incidence of autism in India?
Okay, so very interesting question. So earlier it was thought that it was 1 in 350, but there is a study done by the North India group, and now they see that the autism incidence could be 1 in 150 is what if for India, but in the US it is thought to be 1 in 160. So out of every 60 child, one is suspect autism for the Americans. But in India, we found that in urban setting, in 110 out of 110 children, one could be suffering from autism, and in rural, maybe 150, one could be suffering from autism. I hope that answers the question. Can we have the next question, please?
Ma'am.
Yeah.
Ma'am, there's a question from M. Ahmed from Bongai Gaon, Assam. He's asking the role of psychobiotic in ASD.
Psychobiotics means?
ASD, ma'am, autism spectrum disorder.
Okay. So a very controversial role. So there is this evidence of psychotropics is very well evident. So what I mean by psychotropic is risperidone, aripiprazole, etc. There is this emerging role of biotics, if that is what the doctor means, about say prebiotic, probiotics in autism. That is a very emerging role yet, though there is a lot of pharmaceutical support available in the market. The study, there is a very nice research which is going on in primary research of the gut-brain axis, which has been done by the ICMR in multiple centers in the country, and the results will be coming out probably by next year about what is the role of probiotics, prebiotics, etc. in autism, and whether the gut-brain axis, what we say, there is some, some evidence in that. But definitely in psychotropics, as in risperidone, etc., in Fludax, etc., have an immense role to control the hyperactivity, the anxiety in these children.
Okay, ma'am.
Yeah.
So Maya, voice, your voice.
So maybe
Sound.
We can't hear you, baby.
Yeah, please unmute yourself.
Sorry, yeah.
Yeah, go ahead, Sumaya.
So next question is by Poonam Panchal from Mumbai, Maharashtra.
Right.
She wants to know about efficacy of DHA.
So again, studies, there are mixed reviews for DHA for autism. There is definite role of improvement in attention for children with ADHD. But for autism, it is mixed reviews which are there. General consensus is that there is no harm using these medicines as adjunct to mainstay of being therapy interventions and psychotropics, and as an adjunct to these, then there is no harm. But the definite improvement in attention and learning which happens with DHA. Yeah. Are there any further questions?
Yes, ma'am. There's another question.
Yes.
From Sampati Pal from Kolkata, West Bengal. She wants to know the rate of autism in preterm newborn.
In preterm newborns. Yeah, so it has been my observation. In fact, there was a very interesting paper which came out from India about 2 years ago. They found that with IVF, for some reason, the incidence of autism is higher in IVF babies. So that is the paper out. In preterms versus full terms, my observation has been that there's not much of difference in autism. However, in terms of learning disorders, there is a very high incidence of learning problems in preterm babies compared to term babies. I've been able to answer this question.
Okay.
Okay. So next question is by Dr. Munin Goswami from Jorhat, Assam. The question is, may absence of social smile at 3 months lead to autism spectrum disorder?
No, doctor, because we've seen that these social symptom milestones are for language and social communication as well as cognition. So I've seen that children who have a cognitive delay later on have a little delayed social functions, social milestones. So just saying on social smile, no. So just a very interesting thing, which is again in research in US, is that and we were part of the collaborative study which is going to be happening next year, is the use of audiovisual AI technique, or not the AI but audiovisual technique. So we have this interactive kind of glasses which are there, and you fix your mobile in front of it, and you can really, it's like a 3D kind of immersive environment that you get. So what this lab has done is they've used these glasses in newborn babies. So kids in whom families in whom one child has autism, and now a second child is born, and now they want to predict in this second child where this child also has autism. So they used these cameras on them, and they found that children with autism do not focus on parent faces compared to who later on develop autism and are picked to have autism, diagnosed to have autism, in the newborn period do not fixate on human faces. They fixated more on objects versus neurotypical children who develop normally. So just saying that social smile not being there could be not really. We need to follow up this child and see progressively till the age of 1 year how he is developing socially as well as cognitively. Yes.
Yes, ma'am. The last question, ma'am, actually.
Yeah.
Dr. Manor from Bangalore, Karnataka, he's asking, writer's cramp or unable to sign from 3 years. The baby takes more time to start the signature. Is it anxiety or any neurological disorder?
I did not understand, doctor.
The question is writer's cramp or unable to sign from 3 years. He takes more time to start the signature. So is it anxiety or any neurological disorder?
Difficult to say without seeing the child. So writer's cramp is now thought of to be a part of, it's called a segmental dystonia. Now, the revised classification, just to go on the neurology part. So it's called a segmental dystonia. So it's now under the umbrella of dystonia type of disorders. So unless we see this child, and what we can do is we have to examine his outstretched hand and do something like a spiral. Okay, in dystonia children, the spiral will be very curvy and it won't be a smooth spiral. So these are some symptoms that we can figure out whether there is segmental dystonia in terms of writer cramp, whether it is anxiety coming in, or it could be intention tremors, essential tremors, etc.
Okay, ma'am. Ma'am, there are more questions, but they are not related to topic, like
Okay.
homocystinuria or
Okay.
cerebral palsy, epileptic disorders.
Yeah.
So,
So we can take those questions, right? So we can take those questions when we have the discussion to those
yes,
particular
yes,
topics. Yeah.
yes, ma'am.
All right.
Okay. Thank you very much, ma'am. Thank you very much for your time.
Thank you. Thank you.
Ma'am, Mona ma'am, we would request you to stop sharing your slide.
Yes.
Thank you very much, ma'am. At the very outset, I would like to thank you for your enriching clinical experience, which you have shared with us today. Today's day is, I think, important on two counts to all of you. One is the scientific visual treat which we got because of India winning over Pakistan, and
Oh, wow.
and that was a visual treat. And this session, the inaugural session of Brain Mantra from you, has been a scientific feast for all of us. That is the right way I could put it across. And it's been really an enriching experience. And I thank you from the team Zuventus, which is the makers of BrainMax, one of our number one prescribed brand in autism spectrum disorder. And I also thank the team, the medical team led by Dr. Sanjay Nawale, for moderating the session. And ma'am, we are sure that this is just the beginning of many more episodes of Brain Mantra to come. And we look forward to eagerly hearing you and your scientific dissemination in the role of neurological neurodevelopmental disorder. So thank you so much to have you here with us.
Thank you.
And I would say good night to all the audience here. And
Yes.
with this, we can call it a day for the session.
Thank you very much.
Thank you, ma'am.
Thank you so much.
Yeah. Bye-bye.
Please
Thank
stop
you so
the this video. Please stop the video. Recording.
Like support, you can stop the recording and get us offline.